Thank you once again. We are going to get started. It's an afternoon for me, so others it will be good morning, good evening, and welcome to the webinar hosted by Christian Connections in International Health on gospel values in community mental health. I should introduce myself. I'm Mwai Makoka. I'm working with the World Council of Churches based in Geneva. I'm Program Executive for Health and Healing. We have two presenters, my friend Julian Ayton, who is the Director for Mental Health with CBM, and will also be joined with Karen Matthias, Mental Health Program Manager for Emmanuel Hospital Association in India. Let me share a little bit about the Christian Connection for International Health. CCIH is a network of approximately 150 organizations, with some mostly are Christian, but also we have 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective, and it provides opportunities for capacity building, sharing of practice, networking, as well as advocacy. Our first presenter is, let me first explain how we are going to have our webinar this afternoon. We'll have the two presentations back to back, and then after that, you'll be allowed to ask questions. We'll not use the chat box at the bottom there. You see there's a slot for chat. Please note that we're not using the chat box, only the Q&A box. There's another box for Q&A. We'll hold the questions until after Julian and Karen have finished their presentations. But you are free to send in the questions, to type in their questions during the course of the presentation. Due to the COVID-19 situation, Karen has not been able to present with us live, but we have her presentation pre-recorded, and we're going to have that. To ask a question, click the Q&A button, type into the space and hit send. If you want to ask your question anonymously, you can check the anonymous box also. This webinar is being recorded. If you registered for the webinar, you will receive a link to the recording. Or you can find it also on the CCIH YouTube channel in the webinar playlists, and it's filed under the resources section, and there'll be mental health in that resources section. I should now introduce Julian Ayton. A medical doctor, is a director for mental health for CBM International, and he is the co-director of the Center for Global Mental Health at London School of Hygiene and Tropical Medicine. He is a psychiatrist focused on public health, and his work involves promoting greater access to healthcare services, social inclusion, and realization of rights for health, and the right for people with mental illnesses and psychosocial disabilities, especially in poor and marginalized communities. He recently returned to London after living and working in West Africa for 15 happy years. He emphasized to say 15 happy years. Initially, he worked in Nigeria, and most recently, he worked in Togo. Welcome, Julian, and feel free as you make your presentation. I should also go ahead and present and introduce Karen Matthias, who is a public health physician from New Zealand and is a researcher in mental health. She has been working in North India since 2006 and is a mental health program manager with the Christian Health NGO Emmanuel Hospital Association. She is the director for the Community Mental Health Program Bureaus in Uttarakhand. Her research and practice has a focus on community participation, inclusion of people with mental distress, gender equity, and health system strengthening in the relationship with community mental health. In absentia, Karen, you are also welcome to this webinar. Now we are going to have the first presentation, and after that, I will not interrupt. We'll go straight to the second presentation, and then I'll speak after the second presentation. Thank you.
Thank you. I hope you're able to see my screen. Can you just confirm that? No, I can. Yeah. Welcome, everyone. Thank you for this opportunity to share with you on this very interesting and rich topic of faith and mental health. It's my pleasure to be with you. I have seen the list of participants in this meeting, and it looks like a great group of people with lots of experience of your own. So I'm looking forward to the question and answer session. Because of the current situation globally, in preparation for this webinar, we decided to spend some time focusing concretely on how we might, as faith-based organisation, as international development, as churches, be supporting response to the COVID-19 virus. So I hope you'll find that helpful. So first of all, I wanted to set the scene really about what I'm planning to talk about. First of all, in relation to mental health and well-being, we tend to think about those two things together, and actually I want to separate them out slightly, to tease them out slightly. When we think about mental health, we're often talking about people who have mental health problems and the way that they can access good care, which is often within the health sector, sometimes also the social welfare sector. And I want to really extend that to think a little bit more about our overarching well-being, about how we engage in a rich and fruitful way with the people around us, able to do our work well, able to participate in the responsibilities we have in society, including in our faith groups. So that's the first thing, that I'm talking really about the spectrum from our overarching well-being, the population's overarching well-being, right through to making sure we can look after and support people who have more significant mental health problems. Secondly, I want to just draw a bit of a distinction between spirituality and religion, because I will be using both the terms and they're not exactly interchangeable. When we think about spirituality, we're normally talking about the personal faith that someone has, that their sense of a relationship with God, and that is often seen as a personal thing, a personal experience. I'm going to be thinking much more about the infrastructure of faith, of religion, about the churches or mosques or ways that people express their spirituality. Both are fascinating topics, but I'm thinking much more in the intersection of mental health, well-being, and religion, and faith-based organisation and faith-based infrastructures in society. So the first, the slide I have up here, you can see that it's a sign a friend of mine took outside of a Hindu temple in Bali. And I will draw your attention to number 6 on this, which says that mad ladies and gentlemen are not allowed to enter into the temple. And really what that demonstrates is that even the place that in many communities is where people should be accepted, is the place which serves people's spiritual needs, and often actually many social needs. In the case of mental ill health and the very large amounts of stigma associated with mental ill health, even those places are often exclusionary. There is a lot of stigma within churches and within other faith-based institutions against mental ill health, and some of that comes from the theology of the different faiths that are in the world. And we need to tackle that head on and address that and talk in those terms with the people who particularly are leaders in those faith communities, and take those traditions seriously if we're going to understand how we can make the experience of having a mental illness less of a stigmatized and exclusionary one in the communities where we're working. In relation particularly to the Christian faith, but also with many other faiths, there are, of course, many ideas that we can draw on to really help us understand how we can engage in the area of mental health. And I've drawn one particular verse out here, which is from John 10:10, which says, "I came that you may have life and have it abundantly." And that's really to emphasize the idea that we are called to be complete people. And I know that in many of your work, and actually in the contribution that the Christian community has made to global health, one of the things that is often strong is the idea of wholeness, the idea that we are more than just a biological being. We often talk in mental health about biopsychosocial components of us as people, and I think we have an enormous amount to offer by adding a spiritual dimension to that, because the great majority of people in the world think in terms of spirituality being an essential part of their being. So we are very well placed as faith-based organizations to meet people in the terms that they understand in relation to mental health. So just very briefly, this is an area that has really exploded in the last 15 or 20 years in terms of finally, I think, receiving the attention it deserves in the field of global health. Prior to that, there was really a neglect of attention being paid to mental ill health, despite the fact that it was increasingly recognized as a cause of an enormous amount of disability, and people themselves would often talk in terms of their mental well-being being central to how they saw their lives being enriched by the kinds of programs that we do in our work in development, or even what the church offers. Those initial years of developing the ideas around global mental health really focused often on reflecting similar ideas in broader global health. But we have increasingly wanted to move from just thinking about equitable access to care, to services, to thinking about the broader social environment in which people live and how we can help them to live those rich and full lives, by also thinking about the issues that might drive them to mental distress and mental illness. So that those recognition of the broader social environment has become increasingly important. And the diagram I have on the slide here is of the Sustainable Development Goals, demonstrating the different parts of the Sustainable Development Goals, the different goals that contribute together to mental well-being. And it turns out that most of them do. We struggle to find one. We struggle to find how the health of the oceans was linked to mental well-being, but otherwise we could basically find something for all of the others. So our programs in poverty are about well-being. Our programs in gender equity are about well-being. And we need to recognize that well-being is actually a common language towards the kinds of outcomes that many of us have in our programs. Finally, I just to mention before we get on later to coronavirus, that in the environments where many of us work, certainly where the focus of much of international development works, many people are very vulnerable. And in fragile economies where the health services and education services are very weak, those are all places where there are many of these social determinants, risk factors towards mental ill health. So there are often people who are very vulnerable to mental distress in the kinds of environments where we work. And they turn to the church. They turn to the religious institutions around them to seek help. Because I've used the term health in relation to mental health very easily and quite naturally. That comes, I think, very easily to us in high-income countries. But actually, in most of the world, people have a very spiritual worldview compared certainly to Europe. And in that worldview, there is a clear understanding of where mental ill health might come from and the behaviors associated with mental ill health. And therefore, that is a dimension that we've often neglected in global mental health, and that churches and faith communities can help to make sure is properly addressed in a positive way as people think about healing and recovery. People think that spiritual element is important. And secondly, that they respond to that understanding of mental ill health in spiritual terms by going to seek help from spiritual places. So that means that people will not naturally think of going to a health service if they have a mental health problem. They will naturally think about going to a traditional healer or a mosque or a church, because that's where they perceive as being the most appropriate place for that kind of support. And I've made the very bold statement here that all the studies that have been done in Africa, which is where I know best, have shown that people first go to spiritual support before they go to more conventional health services. And that's true. Whenever that work is done, it's always found that people first go to spiritual places, and that's particularly in rural areas and less wealthy areas. But it's true pretty well across the board. And where people do become more middle class, start to have more of an understanding around mental health as a health issue and start going to health services, they continue to retain the idea that there is an important spiritual component. And that's something that we need to continue to address throughout our services. So how do those spiritual and faith-based organizations tend to respond? Well, in many cases, it is where people find great support. They value the guidance that their faith leaders can give them. It also works for them in their own spiritual practice if they're able to have guidance in relation to how their problems relate to their spirituality. And for example, people find great comfort in prayer. Many times, mental health problems, particularly if it's at the level of anxiety or distress, are actually caused by environmental problems, relationship problems, and often, obviously, spiritual leaders are very well placed to try to also address those social problems. Unfortunately, people also experience exclusion. They feel judged. They are told that they don't have enough faith if they're not getting better, or that there is a reason why they're suffering this, that it's associated with a sin they've committed or something sometimes that their ancestors have done. And in many cases, unfortunately, there's been a number of reports just in the last couple of years that have shown very, very serious human rights abuses happening under the traditions of either Christian or Muslim or other faiths. And this is pretty well across many, many countries. And it is often associated with places where there are no conventional health services where people can turn to, because in that case, there is often very difficult behavior among people with very severe mental illness, with conditions like schizophrenia, and families don't know what to do. And they will often seek a solution that involves some kind of containment. So there's a picture here of a person having some shackles sawn off his wrists. And that was very typical of how people were brought to us in the program I was working in Nigeria, where people could not cope and they would end up chaining their relatives. And the first thing we often had to do was to remove those chains. Obviously, families were very distressed by this, by having to do this, but they felt they had no choice if that person's behavior was often a danger to themselves or to other people. So we are on very strong ground in relation to current best practice thinking in how we can support people as they come to healing and recovery if they have mental health problems. There's a very well recognized intersection between biological, psychological, and social factors related to mental ill health. And that really maps onto the kinds of treatment that should be offered to people, that should be a comprehensive arrangement that allows people to have problems that might be in any of those areas addressed. But in the case of churches and faith-based organizations, we're very much able, I think, to add a spiritual dimension to what people are going through and add an element of healing in relation to their spirit as well. And that's something that I think actually pastors are very good at, and their skills that people can develop and grow in order to do a better job of that. But we also need to make sure that those people who are in positions of authority have a clear understanding of a compassion orientated response to people whose distress they see, because we know that can go a very long way towards making people feel better and not making people feel bad. So I want to give a very brief example before we move on to the COVID examples I'm going to mention of the work that we did in Sierra Leone a few years ago. This was actually immediately after the Ebola crisis in West Africa. We recognized, as we were setting up primary care services across the country, that the local traditional and faith leaders were an essential component of the local infrastructure of care that people were using. And we really wanted to engage with them to make sure that we could work collaboratively and positively with them. So we set up what we called community forums, where the local psychiatric nurse who would be running the clinic in the long term was able to bring these people together and spend time with them, understanding their different perspectives, what work they were already doing, what services they're already providing for people with mental health problems, and how they could perhaps work together to solve some of the problems that the traditional and religious leaders weren't able to do, weren't able to respond to well themselves. So the main focus really was first on listening and understanding what people were already doing, rather than doing what often happens in the case of health education, which was to go and tell people what they should be doing first, or to condemn what they were doing. We needed to spend more time listening. Of course, we did share health messages. We did talk about what the nurse would be able to offer in the primary clinic. And then we tried to come to a common understanding of what the role of the conventional health service might be, and what the role of the traditional or religious leaders might be in those communities. People really valued that approach. People really recognized that medicine had something to offer. There are some faith traditions that will actively say, you must avoid going to psychiatry, you must avoid going to mental health services because it's a spiritual problem. Increasingly, we find that that's a minority view, and that actually people are very able to adopt the view that, of course, they have prayer to offer, they have maybe even some kind of exorcism in some cases, they have something to offer that's on a spiritual level, but they will also recognize that if a person's epileptic seizures are not stopping, or if a person is not getting better who has schizophrenia, there is a point at which that person, that family, will benefit from going to conventional care. We did find that it was helpful to have some thinking done in advance, and even some church leaders who were able to take the pastors through specific thinking about theology. They really respected and valued that, and that was a really helpful thing to do, which does mean you need to think about doing that also for traditional healers, also for other faiths who come. In Sierra Leone, it was imams, pastors, and traditional healers. So what can the church do? How can the church be a positive contributor to improving population mental well-being? First of all, I'm talking really directly to people who are in church infrastructure, or people who might work with churches now. I think it's helpful to come to a common understanding about what mental health, spirituality, how those areas link up together, and to come to an understanding among church leaders of what the church's role should be. So to develop a program, a sense of what they would ideally like to see their local congregations receiving from the church leadership at a local level. That's going to be different in every country, but there is a very well organized hierarchy of infrastructure of churches, which makes them very well placed to do this, as well as already, of course, being well placed to be responding to people's mental health needs, because people are already seeking that. it's then really important to engage with local church leaders to help them to come to a common understanding of what the church's position is. And that has been happening now for some years in many countries, and certainly many of the messages that are coming through from the church in the UK during this coronavirus crisis have actually been about well-being very directly, also linking that well-being to being able to access spiritual support from the church where necessary. And then I think there are many ways in practice that understanding among local church bodies can really be facilitated towards meeting people's needs. Of course, the spiritual and church-based activities themselves can play an important role in supporting people. There are many groups associated with churches within which well-being and thinking about mental health can be facilitated. And then churches obviously have concrete health services. They have mental health services as part of their hospitals or their outreach programs or their social welfare programs. So in all of them, there should be a good mental health component. I would draw your attention to a document that was published a couple of years ago now, really forming some very good practical guidance on how faith-based organizations can support, particularly in humanitarian settings. But actually, I think it really works across the board. In relation to the current coronavirus pandemic, this has obviously taken us all by surprise, but it is an area, I think, where the church has an enormous amount to offer. I'm going to just go through the basic recommendations that have been developed by the WHO and the international infrastructure for supporting pandemic response, which I was involved with developing and which I think make a lot of sense, including for churches to be sharing. And that's the responsibility of churches, I think, at the moment, to be sharing good quality evidence and advice at a time when, of course, it's fertile ground for conspiracy and for inaccurate information, which can really cause a lot of damage in itself. So first of all, we need to be thinking about conveying very clear health messages. And that, of course, in this case means hand washing, physical distancing, but encouraging communication between people, especially online, via telephone, that kind of thing. We need to, as far as possible, continue to be a place where people can get support of a more social nature and a spiritual nature. And my church closed last week, so we are having to work out how to have Zoom meetings at the moment. And I know many countries have now already banned gatherings. And so churches quickly need to make sure they continue to provide the very important support they have historically done. We need to particularly take responsibility for very vulnerable people in our communities, people who would be isolated if it wasn't for us actively seeking to find them, and continue to make sure they have support in a very practical way often, especially if they're on their own, or particularly vulnerable people with disabilities, elderly people on their own without families around, for example. Where helpful and where you have the right people in the church, it's really helpful to be able to provide counselling for people who are particularly distressed, and that often is a skill of church leaders and particular people within the leadership group of a church. And then finally, where there are people whose distress cannot be contained and supported by counselling provided by a church, it's important that the church has at its fingertips the right routes where people can find further help within mental health services if possible. I'm going to end there. I think I've gone slightly over time, and I look forward to hearing any questions you have later. Thank you.
Thank you, Julian. We now proceed with the next presentation. Thank you very much, our two presenters, Karen and Julian. Just a reminder to type your questions in the Q&A section. So far, we already have 4 questions, and I will ask Julian to to have a first look at them. Just a quick understanding, we have heard of the interrelatedness of issues. Mental health cannot be seen and should not be seen in isolation. And indeed, all the other health issues, and the current pandemic is a case in point. It's not just a health issue, it's touching every aspect of our society. And in so doing, we had the slide which looked at the proximal and distal factors. Some factors, yes, they are much more closer to the issue, but that should not make us forget the related issues which are a little more distant. We have heard about what I can say a need for a healthy balance between or let me say, to avoid the two extremes, medicalization of mental health and versus spiritualization of mental health. Mm-hmm. We should avoid over medicalization of mental health, and we should also avoid over spiritualization of mental health. Mental health has a spiritual dimension and also has a medical dimension, as well as the other issues, social issues and all that. So we need a healthy balance. And we have also been ably engaged on community engagement. We always use the word community engagement, but what we have seen in this presentation is an addition of an adjective, meaningful community engagement. And we have seen examples of how meaningful community engagement can be in the two presentations. And it's not just meaningful community engagement, but also engagement of the clients themselves. The people that we are helping directly, they also need to be meaningfully engaged. They should be part of the solution. We had the term physical distancing as we are discussing coronavirus, which I think is very important now. And I'm not liking the word social distancing, because we don't want people to be socially distant. We want people to be socially connected, spiritually connected in our communities, with our colleagues, with our friends, while we are maintaining physical distance. So we need physical distancing with social connectedness. Numbers of mental health workers are critical, and the priority that is given to mental health is also very critical. You might later see a link on the World Council of Churches. We have a publication, a reflection on World Mental Health Day, and there's a link on the CCH website. You can look at the reflection on World Mental Health Day, which is coming later, but there are some reflections there, biblical reflection on mental health. Julian, would you like to take one or two questions?
Okay. Yes, thank you. Thank you for those important points, Mwai. You're right. It is often a question of balance, actually, and respecting different traditions, but finding a way where actually there's a combination of needs that people have, which we can actually work towards addressing all of them. Thank you for this opportunity. I'd like to start with the first question here, which is actually about disability inclusion. It's a topic close to my heart because I work for CBM, which is an organization primarily focused actually on inclusion of people with disabilities in the work that we do. There's 2 points I'd make really. First of all, that people with disabilities of all kinds have more likelihood of having mental health problems because they're an excluded, stigmatized group, who are more likely to be poor, who are more likely to experience abuse, for example. So we certainly see mental well-being as a component of broader disability programs, and that actually counts very much for all programs. The idea that mental well-being is should be a part of all programs in development and should be a part of church life. We also have found great value in thinking about people with more severe mental health problems who are disabled by them as being a group of people who can identify as having a disability. That has been a really helpful way of getting them more rights of actually helping them to think about claiming their rights and being actively engaged in making sure we can, for example, think about stigma and exclusion within the really helpful frameworks that the history of disability work has brought us. So the specific question is around how we convey messages to people who have hearing problems. And this was a really important learning we had during the Ebola crisis, and we're actually putting into action, I hope, quite quickly with partners now to make sure that the people who are not able to easily access messages in relation to coronavirus, for example, are not left behind, that it's not a death sentence because you can't hear messages or that you can't see messages. So churches are very well placed, development programs are very well placed to make sure that particular groups of people who might not access good messages that might save their lives or make them less likely to transmit a virus to other people are able to learn to understand those. And usually the most helpful way to do that is to work with disabled persons organizations. There is normally a National Disability Federation, there is normally a National Blind Union, people who know sign language, and they can be a really important support to enable the same messages usually to be conveyed also to people with disabilities. And then on top of that, sometimes thinking about the particular needs of people with disabilities that might be over and above the same messages as everyone else. For example, people who need care at home, how do they continue to receive that care at home when the health service is not functioning as before, or there are extra measures that need to be put in place to avoid infection? So thank you for asking about people with disabilities. It is something that we should all really be thinking about as an integral part of the work that we're doing.
Thank you, Julian. One consideration actually with people with disabilities, especially hearing impairment or those that are visually disabled, is the ongoing investment that is required. When I worked in the national HIV program, there were demands and plans from the human rights perspective and also the disability organizations to print IEC materials and documents and all that in Braille, and to have translation in television, in sign language and all that. I was a policy manager, I was responsible for policy. So my question was, how many blind people in Malawi can read Braille? The assumption is that as long as you're blind, you can read Braille. And many of them have not gone to school so that they can read Braille. Many have not been trained in sign language so they can understand sign language and they can communicate in sign language. And that cannot be fixed during an epidemic. And when an epidemic is over, these people are forgotten. So as health workers, we need to be advocates. In my country, Malawi, there are only a handful schools for the deaf, 1 or 2 schools for the blind, and these are only run by churches. When you go there, you cry. They receive almost nothing from the government. And there are thousands and thousands of, maybe close to 1 million when you put those with hearing impairment and those that are blind. And they are basically forgotten by the system. And so it cannot be fixed by translating COVID messages into Braille and having sign language because you will not reach them. So this is my plea that actually in between times of crisis, we should not forget those that are marginalized. Is there another question?
Shall I answer? There's a couple that I think we could easily put together here, Mwai.
Yes, strategies for working with interreligious dialogue, interreligious conversations. And there's also how do you train community health workers or indeed health workers in general so that they are sensitive to spiritual dimensions?
I think the first thing to say is I think there's a gap in this area. that many people are doing good work. There's quite a lot of resources, for example, in the theology and thinking around Christian faith and mental health available, but they tend to be in different countries and by different organizations. There isn't, I think, a good common consensus resource available. And that also goes, unfortunately, for good training for community health workers and other health providers. So I'm afraid there's a gap there that needs to be filled, although there are some good resources in different places. Mwai mentioned some thinking on the World Council of Churches website, and there are some others. But I'm afraid there isn't one particular place I can point you to for training curricula for community health workers, although I know some good work has been done. The question that I thought was interesting was around how we work with traditional and religious leaders, encouraging them to engage with health services without undermining their authority. And that's a really core question, a very good question, because unfortunately, the way that this has historically been done often does undermine authority, or at least implies that they don't know what they're thinking is wrong. And that the reason I presented that idea of the community forums is because you have to start from a perspective of mutual recognition and respect. There is also the very concrete problem that some spiritual leaders, some churches, some traditional healers have a strong income stream from this, even if it's just containing people in prayer camps and things. So we do need to call out human rights abuses where we see it. If possible, there's no reason why people couldn't continue to have that service provided, as long as it's linked up with subsequently providing the appropriate health care as well for people who are not going to benefit from long times spent in prayer camps, for example, especially if they're very abusive, like some of them are in different parts of the world, unfortunately. But approaching people with a respectful attitude that is actually what they receive from their local populations, who do respect what they have to offer. To start from that perspective is often the best way to move forward. And then they actually can often have their status increased by being acknowledged by the health system as a contributor to the overall population well-being, which historically that's often not how they have been treated, but it is possible to set up that kind of relationship.
Thank you. We have just a few more questions. I think we need to reclaim more space in terms of values-based training. The training that is copy and paste is not helping. Yeah. So we need to have some advocacy at the country level to start some reforms in the curriculum. And a good starting point is that churches have many training institutions where they train health workers. And these are an easy entry point to bring values and sensitivity to the religious and spiritual dimension of health. There was a question about, from Sunita, what do we say to Christians that we should actually stop congregating when God is all powerful? I was starting to type. I was talking to my mom yesterday. She is 75. And I said, Mom, please don't keep going to church. And she says, no, I'm not stepping my foot there. Because the Bible says, don't take God to the test. And she quoted that message from Jesus Christ, that when you see danger, you cannot step forward praying to God that he should take care of you. So that is nonsensical. It really like taking God to the test. So we have the knowledge, we have the information, and that information has been given from God himself to help us take care. And so we can use that if we're deliberately stepping into danger, then it is not faith, it is something else. I think we have come to the close of our time. We have, I think we have There's a comment there. I believe the Lausanne movement has an issues network on mental health. And Grace says, in the beginning, HIV/AIDS programming in Uganda, we trained numerous lay counselors to help families deal with HIV and AIDS. One of the challenges was to have them realize that they were not there to fix the problem, but to listen. Thank you very much. Listening is a starting point. Where there's no psychiatrist is a good resource for community training, though not particularly faith related. Okay, where there is no psychiatrist, try to remember that and search for it. Mental ill health is directly affected by loss of meaning and disordered attachments. Is meaning making using religious language or the patient's religious background important to utilize and respectively connecting it with Christian understanding? Okay, we'll not get into that, but that's a good pointer from Dan. To overcome over-medicalization and over-spiritualization of mental health issues, are there appropriate resources available for pastors or other religions leaders to help them properly understand a mental health challenge that is referred to them? There may be many. I think we can share the resources through CCIH, but the publication which I referred to are the reflections on health for churches, were an attempt for me to provide a starting point where the religious leaders and the health professionals can have conversation. I think we need to have documents that provide a starting point, areas of convergence, and there will be growth from there. So I think these are pointers that we need to find ways of continuing this conversation. Julian and Kathy, Mona, and the rest of the leaders, we hear that. I think we should not end this conversation now. It has to be ongoing. We have tried to respond to the issues that were raised. As a webinar, it's really, sometimes I don't like the question and answer. It's like we have all the answers and you are only supposed to tune in for you to learn new knowledge. No, some are comments, some are supposed to be pointers, some are supposed to be interjections, and all those are very welcome. And I should thank you all for sparing your time to make this webinar very meaningful. We had 31 online participation, which is very good. This webinar is going to be, as it has been recorded, it will be available on the CCIH website, alongside the presentations that were made. You check it and it will be under the resources section there. You will also receive a short questionnaire, maybe from tomorrow, as well as the others who did not attend. They'll also get that and they'll get a link to the recording, just for you to give your inputs and on how the webinar, what you think about the webinar, just for us to be able to make some improvements in the next presentations. Thank you very much. We shall close with a word of prayer, and after that, we wish you a very wonderful remainder of the day, and also the rest of your efforts, especially as we respond to the outbreak. Let us pray. We thank you, our Lord and our God, for the grace and mercy and technology that you have allowed us to conduct this webinar and to share fellowship and knowledge and information. Thank you for our two dear presenters, Julian and Karen, and for the wisdom, the motivation, and also the sacrifice they have put in to make preparations for this, in addition to the many other pressing demands on their time. And also all our friends who have taken time to listen, to tune in, and to make comment and interact. You say in your word, it is good that we live together in unity and in fellowship. Even this fellowship, Father, is blessed by you. Be with us, bless all our efforts, and bless all our families as we continue to serve you. In the name of Jesus Christ, we pray. Amen. Thank you very much. Have a wonderful day. Thank you.
Thank you. Bye-bye.
Bye-bye.